What are some common induction therapies?
In the United States, the most common induction regimen is called RVD, which stands for Revlimid, also called lenalidomide, Velcade, also called bortezomib, and dexamethasone. And there are different variations on this three-drug combination, where the bortezomib can be given twice weekly or once weekly, where the regimen can be 3 weeks long or 4 weeks long. But regardless, some variation of RVD is the most common regimen used. Sometimes in patients who are more frail, we might select a two-drug combination. So for instance, we might pick either lenalidomide or bortezomib and combine that with dexamethasone as initial therapy. Or we may use reduced doses of the three-drug combination. There are certain circumstances where we might consider other options. So for instance, a patient with kidney injury from his or her myeloma at diagnosis sometimes may start with either the two-drug regimen, bortezomib and dexamethasone, or more commonly, an alternate three-drug regimen, such as CyBor-D. CyBor-D is a regimen where instead of using lenalidomide as part of initial therapy, cyclophosphamide is substituted for it. And the reason for that is that it's easier to use in patients with renal injury. More recently, there's been some data, exciting data about combining the antibody daratumumab, which is also called Darzalex, together with chemotherapy as part of induction therapy. This is building off of an experience that we have combining the antibody with other myeloma therapies in relapse disease, and it definitely enhances the efficacy of the regimen. Right now, there's one approved regimen combining one approved induction regimen combining traditional myeloma therapy with daratumumab, but it's not a combination that would be used commonly in the United States. And we're in the process of conducting studies adding daratumumab to regimens like RVD for induction therapy. I think there's a high likelihood that in the future, the addition of antibodies is going to become more standard.
Since the recording of this video, 2 induction therapies using Darzalex have been FDA approved. These are Darzalex, bortezomib, thalidomide, and dexamethasone, or DVTD, for adult patients with newly diagnosed multiple myeloma who are eligible for autologous stem cell transplant, and Darzalex, lenalidomide, and dexamethasone, or DRD, for adult patients with newly diagnosed transplant-ineligible multiple myeloma. Why use a 3-drug combination?
So the reason we typically select 3-drug combinations is because in head-to-head studies, 3-drug combinations generally beat 2-drug combinations. A classic example is the SWOG S0777 study that compared the 2-drug combination lenalidomide dexamethasone to the 3-drug combination of those 2 drugs plus bortezomib, and that 3-drug combination is RVD. And in that study, it showed that the response rates were higher with the 3-drug regimen, the response quality was higher, and the duration of responses was longer. And then that's pretty representative of what we see in studies that compare 3-drug combinations to 2-drug combinations. Based on that, we always tend to select those therapies. In my own practice, the question that I always ask is there a reason I can't give a 3-drug regimen? And again, it usually boils down to the frailty of the patient. So while there are definitely some patients who get 2-drug combinations, I think the default standard now internationally is triplet therapy.
I think in 2017 there was convincing evidence from a randomized study that is quite old, the so-called SWOG study that used the RVD versus RD combination. So this is bortezomib, lenalidomide, dexamethasone versus lenalidomide, dexamethasone in the newly diagnosed setting. That study showed that 3-drug combination is superior both in newly diagnosed standard risk and in newly diagnosed high-risk patients compared to the 2-drug combination. There are a lot of other studies, smaller studies and phase 2 studies that have looked into combinations with 3 drugs, and they have shown previously very, very favorable outcomes in both high-risk and standard-risk patients. So I think the evidence from the literature strongly supports the use of 3 drugs. That is what the field is in agreement with, and we would do that here as well.
What do you see in the future for induction therapy protocols?
It was very striking to me to see that there are actually multiple 4-drug combinations. In fact, the RVD, the KRD, and even IRD backbones that are in a way similar, they all are now being tested with combinations of CD38 monoclonal antibodies, and there are also SLAMF7 antibodies. The strongest signal seems to come from either RVD with CD38 monoclonal antibody, and perhaps the strongest, the KRD regimen with CD38 monoclonal antibody. My prediction, looking at the data that has been presented so far and with the insights I have, I think that 4-drug combinations will become the future paradigm for multiple myeloma.